Buenas tardes. Paso al castellano porque nos están escuchando en streaming. Me dicen que tenemos 700 personas inscritas. No sé si las 700 estarán escuchando, espero que sí, pero al menos con interés se han inscrito en estas jornadas. Yo creo que me conocéis, pero para aquellos que no me conozcáis, yo soy Álvaro Agustí, soy neumólogo y soy el director de la Cátedra de Salud Respiratoria. Y quiero aprovechar para agradecer a 3 compañías, AstraZeneca, Chiesi y GSK, por el apoyo que dan a la cátedra que nos permite hacer actividades como esta. Además, en estos momentos soy el presidente del comité directivo de Gold. Y como tal, puedo deciros que un objetivo muy importante de Gold no es solo escribir unas recomendaciones, que está muy bien y os puedo decir que lleva mucho trabajo. Ya estamos trabajando en las del 26, es un año de trabajo. El objetivo también es diseminarlas, porque no basta con escribir unas recomendaciones si luego pues no se diseminan. Y, por tanto, desde Gold se estimula que se organicen este tipo de reuniones que hemos llamado Gold Satellites. Y os puedo decir que estas se hacen en España, pero se han hecho otras en Italia, en el Reino Unido, en Sudamérica, en China, y por tanto lo que se pretende es que las recomendaciones de los expertos de Gold pues lleguen al máximo número posible de médicos o de pacientes o de personas interesadas en la EPOC. Hoy el programa consta de una primera parte del profesor Klaus Vogelmeier en Alemania, desde conexión virtual, nos presentará los principales cambios que se proponen en Gold 25. El doctor Vogelmeier es el director o el chairman del comité científico de Gold y, por tanto, nadie mejor que él para explicarnos los cambios que en el año 24 hemos estado discutiendo, os puedo asegurar, de manera muy intensa. Y después tenemos a 2 expertos en EPOC internacionales, el doctor Marc Miravilles, que tenemos aquí, todos lo conocéis, español, catalán, Barcelona. Con él hemos trabajado en muchas ocasiones. Marc, muchas gracias por estar aquí de verdad, no en una pantalla. Y el profesor Leo Fabri, que seguramente también conocéis todos, otro experto mundial en EPOC, está en Italia y él se dirigirá a nosotros telemáticamente. La idea es que la primera media hora aproximadamente el profesor Vogelmeier nos hará un resumen de los cambios que hay en Gold 25 y después yo le he pedido al doctor Miravilles y al doctor Fabri que los comenten. No sé si los criticarán o los ampliarán o los apoyarán, pero les he pedido que ellos nos digan de los cambios que el doctor Vogelmeier presentará, qué opinan ellos. Por tanto, el profesor Vogelmeier tendrá diapositivas, pero el doctor Miravilles y el doctor Fabri no. Lo que nos van a dar es su opinión. Y finalmente tendremos, depende de cómo vayamos de tiempo, entre 10 y 20 minutos de preguntas. Y las preguntas se pueden hacer aquí, de viva voz, o los que nos estén escuchando por la streaming, pues pueden ver en el chat del streaming y yo las veo aquí. Ya tengo una primera pregunta. Alguien me dice, buenas tardes, ¿la sesión quedará grabada? La última media hora no puedo estar. Sí, quedará grabada y la subiremos a la web de la Cátedra de Salud Respiratoria y quien no pueda verla ahora la podrá ver cuando le parezca más adecuado. Dicho todo esto, ahora me tengo que ir al inglés, porque el profesor Vogelmeier, por supuesto, nos presentará en inglés, el profesor Fabri también, y el doctor Miravilles también, porque aunque él puede hablar en español. Si lo habla sus comentarios en español, el profesor Vogelmayer no se va a enterar de nada, con lo cual yo le he pedido que sus comentarios los haga en inglés. Sin embargo, la discusión volveremos al castellano. Si alguien quiere hacer preguntas aquí en castellano o en el chat en castellano, pues no hay ningún problema. Y si hay que traducirlas, las traducimos. Y si alguien las quiere hacer directamente en inglés, pues también las puede hacer. Por tanto, esperamos, hemos empezado puntuales a las 5:30. La idea es no alargarnos más de las 7, por tanto, 1 hora y media. Y espero que les parezca interesante y que tengamos un debate también animado. ¿Podemos hablar con el profesor Vogelmayer? Klaus? Oh, hi Klaus. How are you?
I'm fine, thank you. Hi, Alba.
I'm fine, thank you.
Hi, Leo.
Thanks for being here. I can tell you that there is about 30 to 40 people here in the room, but there is 700 people listening in the streaming. So people is very interested in what you have to say. I just told them that you will have about 30 minutes to explain the main changes. Then Leo will ask you or will give you his feedback, and Mark will give you his feedback too, and then hopefully we might have some 10-15 minutes discussion at the end. So thanks again for participating here. All yours. Go ahead.
Okay. Thank you, Alba. Ladies and gentlemen, dear colleagues, it's a great pleasure for me to present the new Gold document or the changes in the document to you. So that's what it's called. It's a 2025 report of the global of the document of the Global Initiative for Chronic Obstructive Lung Disease. I'm not speaking here on my own behalf. I'm speaking here on behalf of all the members of the Gold Science Committee. So these are my personal disclosures. And I will go through the document from front to back, so more or less page by page or chapter by chapter. And of course, at the beginning, we have to talk about diagnosis. And then, of course, we have to talk about spirometry. And now the chapter on spirometry has been updated. And we dealt with the issue of C-scores and LLN values and reference values. So let me start with this slide that very nicely summarizes the problem when you compare the fixed ratio that we recommend in the document with a lower limit of normal. As you know, when you use fixed ratio, there may be the potential risk of overdiagnosing elder patients and underdiagnosing younger individuals. And when you sort of summarize the pros and cons of fixed ratio versus lower limit of normal, as Jürgen Vesper has done this on this slide, you see the differences very nicely. I mean, fixed ratio, of course, is simple. It's been established. All the pharmacological studies that we have in the world of COPD have been done based on fixed ratio. Of course, there is a risk of overdiagnosis in the elderly. There is no dependence on reference values. And of course, generally speaking, lower limit of normal is more correct physiologically. But on the other side, there are data like this one, and that's not the only data point that suggests this. This is a paper from Dan Manino and others published some time ago, where they analyzed the impact of changes of based on different reference values on mortality. So lower limit of normal, normal and gold normal is at what you see is the green bar at the bottom. And what is very interesting when you look at the red bar, these are patients that are normal based on lower limit of normal, whereas gold with the fixed ratio says they're obstructive. And as you nicely see, they have a quite increased mortality. So obviously, there is something that goes beyond just looking at reference values that has an impact on mortality. We do not understand that as yet, but there is a signal suggesting that fixed ratio regarding prediction of mortality may be even better than lower limit of normal. And of course, all these reference values and lower limit of normal issues and so on are based on epidemiologically based studies. Whereas in clinical reality, we have a patient that has symptoms and that has risk factors. And if this is the case, then we do spirometry to confirm the diagnosis. So the situation in these epidemiologically based studies is quite artificial compared to the clinical situation. Now, there has been a lot of discussion about reference equations in the last years. And there has been so far, or in the old days, we used race-corrected reference equations. And this can lead to an underestimation of disease severity and the effects of malnutrition and childhood illness on lung development. And therefore, some years ago, race-neutral equations were proposed. And there is now a big study published in the New England Journal of Medicine this year that compared the impact of the old race-based global lung function initiative data from 2012 with the new ones, the race-neutral equations from 2022. And here you see that nearly 370,000 individuals went into this analysis. And the authors compared the clinical, occupational, and financial reclassifications based on one or the other reference equation system. And I'm going to share with you only clinical outcomes. And here, gold grade of 2 or bigger. And you see the lighter bars represent the old race-based equations and the darker bars represent the race-neutral equations. And as you see, for most races, there is no difference or very, very tiny differences. There is a major difference for Black individuals where there is a difference of around 44%. There were other parts of this study that showed that there may be impacts on financial recompensations, for example, for workers, that may play a role. But clinically, the differences are quite small. But anyway, based on that, we decided to recommend the global equations, the GLI global race neutral equations, although we are aware that there are problems with that. They did not include participants from many countries or global regions. They observed population differences, body proportions. That's a problem with these reference equations, and they need to be, there's no doubt, in the future, they need to be improved and enhanced and widened regarding the spectrum of evaluated populations. Now, when it comes to the issue of pre and post bronchodilator spirometry, we have a new graph in the document. And let me guide you through this graph. And this here says, measure pre-bronchodilator FE1 FVC ratio. If this is lower than 0.7, less than 0.7, then we suggest that you measure post-bronchodilator FE1 FVC. If this again is less than 0.7, we think it's fair to say that COPD is confirmed. If then there is an increase in the normal range, then this is a flow response. And this patient needs follow-up with repeat assessment. If the pre-bronchodilator FE1 FVC is normal, we think it's fair to say that there is no COPD. And we suggest that you should only measure post-bronchodilator FE1 FVC if you think that there may be a volume responder based on a low FEV1 or high symptoms. Now let me explain to you why we make this recommendation. This is from a paper that Dave Singh submitted recently. And you see here the analysis from COPD gene and Spirometry, two North American big smokers cohorts. And what I would like to focus your attention on is this so-called pre-O, that means pre-bronchodilator obstructive, post-N means post-bronchodilator normal, pre-N means pre-bronchodilator normal, and post-O means post-bronchodilator obstructive. And as you nicely see, this was marked here yellow. These are individuals that we could call flow responders. These are the ones that are sort of less than 0.7 before bronchodilator and move into the normal range when you give them a bronchodilator. Those are the ones that you should keep a track on and follow them in the future because they may become obstructive longer term. When you look at this group of individuals that was only found in COPD gene, these are the volume responders. These are the ones that are normal before and obstructive after giving them a bronchodilator. But when we look at the numbers, you see very nicely here that altogether around 10,000 individuals have been evaluated, and only 300 of these 10,000 individuals qualified for that. So suggesting that this may happen, but it's rare or even very rare. Now, in the document, we included now a new chapter on cardiovascular risk, and there are two options when it comes to cardiovascular risk in COPD. And there may be clinically stable COPD, and in clinically stable COPD, there is a high prevalence of cardiovascular disease, of all kinds of cardiovascular diseases. And with regard to acute exacerbation, there is a major cardiovascular risk during and after exacerbations. And do we understand why this is the case, why there is a cardiopulmonary risk attached to COPD? We don't know yet. There are three mechanisms that are right now considered to play a role. One is inflammation, one is hyperinflation, and one is hypoxemia, the last one in particular during an exacerbation. And when we look at how often this occurs, this is from one study that evaluated the frequency of cardiovascular diseases in COPD. The size of the circle represents how frequently this disease is observed. And as you can nicely see, some of these diseases are very frequent: arterial hypertension and coronary heart disease. And as I said, there is a vulnerable phase in the aftermath of an exacerbation. On this slide, you see the analysis of an international consortium called ICSECOS that evaluated this phenomenon in many countries. And here you see the cardiovascular diseases after a severe exacerbation. On the ordinate, you see the time frame. It starts 1 to 7 days on top and more than 365 days at the bottom. And on the abscissa, you see the hazard ratios. And there are two findings here that are very relevant. The first one is this one. So in the first week after an exacerbation, there is a risk increase of around 20-fold that a patient may develop a cardiovascular complication. And this signal over time is not that prominent anymore, but even after 1 year, there is still an increased risk, and the risk increase is about 50% compared to normal, suggesting that these patients are vulnerable, and they are vulnerable for a very long time. And with this as a background, years ago, we already decided to put this into the document that we suggest we make certain recommendations regarding follow-up period, 1 week to 4 weeks follow-up and 12 to 16 weeks follow-up. And at the bottom, you see here in the blue frame, determine the status of comorbidities. But I must say, we all believe that this is not good enough. So in the years to come, we will go much more into detail. We think we have to make very clear proposals. What should be done while the patients are in the hospital and how they should be followed up. Now the chapter on computed tomography has been updated. What's the use of computed tomography? First of all, we learned already years ago that computed tomography is extremely good to detect and quantify emphysema. So it can be used for defining the extent of emphysema, the distribution, and the type. We also learned from the lung cancer screening trials that the CT scan is very good in detecting lung nodules. In the last years, there was a focus on airways, bronchiectasis, and mucus plugs. In addition to that, CT scans can be used to analyze COPD-related morbidities. Now here you see a typical CT scan of a COPD patient. And by the way, I think that's the first representation of a cigarette box in a CT scanner. And by using smart ways to analyze the CT, you can not only find out about lung structure and lung cancer, but you can also quantify bone density. You can detect coronary artery calcifications. You can quantify them, and you can also learn about muscle loss. And when we think about the identifying multimorbidity in patients with COPD. This is a paper, Leo Fabri was the first author in Lancet Respiratory Medicine. And here you find the 5 groups of diseases that you should take into consideration COPD patients. First of all, of course, the lung, regarding the COPD, but also regarding cancer, depression and anxiety, cardiovascular diseases, and osteomuscular abnormalities. And many of these diseases you can identify and even quantify by performing a CT scan. And how valuable is that? To give you an example, this is a very nice study published in Respirology 2022. And here the CT-based diagnosis of comorbidities was compared to the clinical diagnosis. So the red bars represent CT-detected comorbidities and the blue bars represent clinical diagnosis. And as you can nicely see, for most of these comorbidities, excuse me, the red bars are longer than for the clinically diagnosed, suggesting that the CT is even better than the clinical history of these individuals. We added a chapter on climate change. We think that this is a very important issue, and we have to, I think in the years to come, we have to even be more precise and elaborate in this regard. But I would like to share with you one data point that we added to the document now, and this is about heat exposure. So we have learned that exposure to heat or cold are both bad for patients with COPD. Higher outdoor temperatures are associated with increased hospitalization. Lower outdoor temperatures are increased with increased exacerbations. And I would like to share with you one data point in this regard from the UK. Here, more than 300,000 individuals were evaluated that were hospitalized for a COPD exacerbation from 2007 to 2018. And not only did the authors analyze hospitalizations, but they also analyzed maximum temperature and other meteorological data. And they compared then COPD hospitalizations with air temperature. And this is what they found. So on the left, you see the unadjusted models. Here you see adjusted models where relative humidity and national holidays were taken into consideration. And on the right side, also air pollution has taken into consideration. And in green, you see the data for males, in orange for females, and in blue for the total population. And as you can nicely see, unadjusted models, there is a clear increase, and it's happening in every age group. The same is true if you adjust the data for relative humidity and national holidays. The effect is somewhat diminished when you also correct the data for air pollution, but for some of this comparison, it's still an issue. So, and this is not the only data point. There are data from Korea, there are data from Germany suggesting exactly the same. So increased temperatures are a problem for patients with COPD. Then we added 2 new drugs to the document because there are 2 new drugs that have been approved. One is Ensifentrine and the other one is Dupilumab. Let me start with Ensifentrine. Ensifentrine is a selective phosphodiesterase 3 and 4 inhibitor. It has potential effects on airway smooth muscle, inflammatory cells, and bronchial epithelial cells. And this what here you see what the effects may be. And this is the end may cause bronchodilation, anti-inflammatory effects, and an increased mucociliary clearance. So what are the clinical data that we have? We have 2 phase 3 studies. One is called Enhance 1, the other one Enhance 2. Both contain about 800 patients. And they received either nebulized ensifentrine, the drug is nebulized, BID, or placebo. Patients were followed for 24 weeks. The primary endpoint was lung function. And let's look at the patients. So here you see the patient population. What is interesting here is that around 30 to even up to 50% of the patients, on the left you see Enhance 1, on the right Enhance 2, didn't have any maintenance medication before the study. Then there are others that had a LAMA, then there are others that had LABA, then there are others that had LABA plus ICS. So this is a very heterogeneous group of individuals. Then in addition to that, most of the individuals didn't have exacerbations. Exacerbations were observed in the last 15 months before entering the study. in only about 1/4 of the population. And this is the primary endpoint. So here you see a lung function signal. On the left, again, enhance 1. On the right, enhance 2. There is an FEV1 and enhance 1. On the right, enhance 2. The red data are ensifentrine. The black is placebo. It seems there is a difference between the two groups, but the populations in these studies, as you have seen, were not enriched for exacerbators. Exacerbations were not an endpoint, and the study was only running for 24 weeks, what is not ideal for evaluating exacerbations. So with this as a background, we sort of put the following information into the document, that it improves lung function, dyspnea, and health status, and it may have an impact on exacerbations, but this has not been evaluated in patients at increased exacerbation risk. And with this as a background, we decided to add ensifentrine to the follow-up pharmacological treatment in this box, where we say considering ensifentrine. These are individuals that still are have relevant symptoms under LABA plus LAMA medication. We are aware that we do not really understand the full potential of this drug right now, but this has to do with the way the phase 3 studies have been designed, and as I showed you. Now let's move on to Dupilumab. Dupilumab is an anti-IL-4, anti-IL-13 drug, and it belongs to the family of drugs that interfere with type 2 inflammatory pathways that are tested right now in COPD. There are now studies ongoing with anti-ST2, anti-IL-33, anti-TSLP, anti-IL-5, and again, the one drug that has been approved recently by the EMEA and by the FDA is Dupilumab. So what's the background situation regarding studies here? So we have 2 phase 3 trials. One is called Boreas, the other one is called Notus. In both studies, there were around, altogether, there were nearly 1,900 patients randomized. Patients were followed for 1 year, and the primary endpoint was exacerbations. And what is extremely important here is to look in the in- and exclusion criteria. And when you look at the inclusion criteria, patients had to have signs of chronic bronchitis. They had to have they had to be symptomatic. They had to have blood eosinophils of at least 300 cells per microliter. They had to have at least 2 moderate or at least 1 severe exacerbation within the year prior to screening. And the background optimized therapy was triple therapy. And physician diagnosed COPD less than 12 months prior to randomization was excluded, and a diagnosis or history of asthma was also excluded. And when we look at the patient characteristics, you see here the number of exacerbations before the trial is more than 2. Many patients had been hospitalized, and nearly all of them were treated with triple treatment before the trial in both studies, in Boreas and Notus. And here you see a pooled analysis of both studies. In gray, you see the data for placebo, and in blue for Dupilumab, here you see the exacerbation rate, and there is a 31% decrease of the exacerbation rate in the patients treated with Dupilumab. In addition, there was a lung function signal. So here you see pre-bronchodilator FEV1, again blue, Dupilumab gray, placebo. What is interesting here, first, there is no sign of tachyphylaxis, so the lung function signal remains there for the whole year. The other thing that's interesting is that the lung function signal occurs early in the study. This is not as yet really understood where this fast improvement of lung function comes from, but it's a quite interesting finding. In addition to that, patients also improved symptoms-wise and regarding quality of life, suggesting that the data are very consistent, and they are very consistent in both trials. And with this as a background, we say in the document that this reduces exacerbations, improves lung function and quality of life. And therefore, we put it on the exacerbation side. Again, both studies that I presented to you, both exacerbation trials with patients groups that were enriched for exacerbation risk. And now we have 3 candidates beyond triple treatment: roflumilast, azithromycin, or Dupilumab. Roflumilast is not used by many patients because of side effects. Azithromycin is not really licensed for use in COPD, so It's sort of a kind of an experimental treatment in every patient, and it has some other side effect issues that need to be taken into consideration. And we say here in the document that patients on LABA plus LAMA plus ICS that have increased blood eosinophils and that have symptoms of chronic bronchitis, these individuals may be considered for using Dupilumab. Now we also added a chapter or we added a paragraph how you should deal with individuals that are on LABA plus ICS. Many patients with COPD are on LABA plus ICS, although this is not recommended any longer by the Gold document. And I will guide you through this proposal here. So patients currently on LABA plus ICS, if they have no current exacerbations and if they had a previous positive treatment response, they had exacerbations before and the exacerbation rate was reduced under treatment. And if they have a low symptom load, you may continue treatment. If they have a high symptom load, you may consider escalating to triple. If patients are currently on LABA plus ICS and they had no relevant exacerbation history to begin with, and therefore there was not a real indication for using LABA plus ICS, then you may consider changing to LABA-LAMA. And if patients under this treatment have additional exacerbations, then you should have a blood cell differential. And if the blood eosinophils are low, you may consider changing to LABA plus LAMA. When they are of at least 100 cells per microliter, you again may consider escalating to triple. So we think that's practical. These are practical suggestions that may help you to make decisions regarding how you deal with patients that are under LABA plus ICS. Then we added a chapter on pulmonary hypertension. This is new, and we had several world experts, including Gabor Kovacs and Marc Humbert, to help us with this. And first of all, what is pulmonary hypertension is when the mean pulmonary arterial pressure is more than 20 millimeters of mercury. Mild pulmonary hypertension is frequent in COPD, severe is rare. And we say in the document that patients with this kind of constellation should be referred to a center, and a multidisciplinary assessment should be performed. And the reason for this is that the classical drugs for pulmonary arterial hypertension do not work in COPD in most patients. What you should consider in all the patients with pulmonary hypertension and COPD that are hypoxemic, you should consider long-term oxygen therapy. Now, this is a difficult topic. We have 5 groups of pulmonary hypertension. Group 1 is so-called pulmonary arterial hypertension, where the problem lies in the vessel wall. Then we have the group that's associated with left heart disease, that's group 2. Group 3, that's the one where we're concerned, or this is the group we are mostly interested in. Group 3, PH associated with lung disease. Then we have PH associated with pulmonary arterial obstructions, or in short, CTEPH, chronic thromboembolic pulmonary hypertension. And then there is group 5, that's more unclear. And in the document, we say now, when you have a group 1, where the problem lies in the vessels, you may treat them according to guidelines. The same is true if it's group 4 with CTEPH, the chronic thromboembolic form. But when it comes to the biggest group, these are the patients with COPD plus severe PH associated with lung disease, the so-called group 3 PH, then it gets very complex. And this is a decision that needs to be made by case by case. You need individual decisions, and these decisions should be made by experts in the field. So let me summarize what I've shown to you. We have now an update on spirometry, including reference values and recommendations regarding the use of post-bronchodilator data. We think that cardiovascular risk is extremely relevant for COPD, and therefore we put emphasis on this. There is an increasing role of CT for lung involvement and related morbidities. We added a new chapter on climate change. I presented to you the data regarding heat. We also talk about two new drugs, Ensifentrine and Dupilumab, that have been added to the follow-up pharmacological treatment recommendations. And we have now a paragraph on pulmonary hypertension. And let me end with a metaphor by one of the greatest thinkers of our times, Yuval Noah Harari, who says in one of his books, "In a world deluged by irrelevant information, clarity is power." It is one of our biggest goals in the Gold Committee to sort of sort out and look into all the references that are published. And this is not that easy as it sounds. For this version of the document, we evaluated around 3,000 papers. So that's a lot of work, and you may get a blurred view when you look at so many papers. And one of our biggest goals is to make things clearer. And we do hope that we succeeded with regard to improving the clarity of the recommendations. Thank you very much for your attention.
Thank you very much, Klaus. As always, that was very clear, so agree, clarity is power. I also said in my introduction that reviewing that many papers and trying to find consensus on what is really important is a lot of work, and you and me know that very well. So thank you very much. I think that this document, Gold 2025, move forward a bit more. It's not the end, but it's moving. So thank you again. Now we have Professor Fabri. Leo, are you there?
Yeah.
Ah, good. Leo, thank you. Wait a minute. Let me thank you first. Thank you for joining from Northern Italy. I hope you could follow Klaus' presentations well. And now we would welcome your view on some of these aspects. Please go ahead.
First, Alvar, thank you very much for the privilege to be here tonight. And thanks, Klaus, for the most clear presentation. It's really magic to see this yearly appointment and update and to see distilled in half an hour, 20 slides, hours and hours of discussion and reading, and the enthusiasm with and efficiency with which the Gold Science Committee works make us all confident that we are update and we offer the best available knowledge to our patients. So I selected a couple of 3 points for discussion. One is the pre and post bronchodilator FEV1 for the diagnosis, the figure 2.6. The second is the severity of airflow limitation. And the third will be a comment on the cardiovascular issue. Regarding the first, I don't have to repeat what Klaus showed. As the last slide, I mean, clarity of the slides is the best selling point of your presentation. On the left arm of figure 2.6, you say if the ratio is normal, above 0.7, this excludes COPD. However, if the clinical background is solid, then you have to consider post-bronchodilator, or in any case, consider repeated measurements, particularly in COPD patients because of their complexity that we don't discuss tonight. Almost never you reach the full diagnosis at the first visit. You need follow-up investigation. You need to consider different comorbidities that may be relevant. So rather than suggesting only a post-bronchodilator, I would say that if appropriate, considering the phenotype of the patient, suppose you suspect that you have component of heart failure, or that you do have a COPD that is underestimated by the ratio, a treatment ex juvantibus, with the bronchodilator, and to see in any case, in each patient, to possibly achieve the best personal FEV1. In the past, in asthma particularly, there was always skepticism about the percent predicted values, because the reference point to calibrating the therapy in asthma, spirometry is part of the criteria to calibrate the therapy. To calibrate the two-minute premium spirometry is to see what is the personal best for the patient. I think that it might be useful to consider these. And the other point is there is a lot of debate, as you are all co-author of the paper on nomenclature, on pre-COPD or early COPD or whatever. And one of the obvious cases is when you have a normal ratio, so you cannot confirm COPD. But you beautifully illustrated the exploitment that you can make of CT scan to see structural abnormalities. So in cardiology, the heart failure with preserved ejection fraction is the combination of clinical and evidence of structural abnormalities. I think that in that case, the combination of the two could be useful to better characterize the patient. The second point is the severity of airflow limitation. I know we have discussed that several times, and I'm a little bit embarrassed to repeat it to you, but I'd like to do it in front of 700 people. That you beautifully described the update of the GLI and the limit and the pros of the predicted values, but those are all predicted values based on pre-bronchodilator spirometry. Now, I'd like to know what was the discussion around this topic to continue to recommend the post-bronchodilator FEV1 also for the assessment of severity, that in my opinion tends to decrease the assessment of severity, because after bronchodilator the change is only transient. By the way, I'm not touching the topic of that follow me of Mark, but the figure that you showed with Dupilumab, with this permanent increase during treatment with the non-bronchodilator drug, that actually resembled very much the experience with the biologic, the monoclonal in asthma, show that, sometimes unpredictable intervention may change the value. So another reason to recommend the correction for the best personal value, as we discussed before. And as you correctly said, the three characteristics are required for the diagnosis. Spirometry is one of those. Always consider the clinical, always consider the other component. The third part is very welcome. You synthesize very well, a large amount of evidence, including from your group, on cardiovascular involvement in COPD. We know from the literature, since a pivotal study by Rutten, by the Dutch group, that there is, in clinically defined COPD patient, there is about 20 to 30% of undiagnosed heart failure. And this has continued over here until recently in Lancet Health. There is a beautiful, again, Dutch study, again from Rutten, showing that by doing an early diagnosis of cardiovascular component, you can increase the number of positive patients significantly by adopting a very simple screening strategy, a strategy that I will recommend. And I think that the message of this part is for each patient with COPD, it should be considered at risk of cardiovascular, like the other cardiovascular factor, hypertension, hyperdyslipidemia, limited exercise or activity. The other point is the emphasis on the exacerbation of COPD, that we still continue to call exacerbation of COPD, but we know that they are more complex than that. And one of the, now we know that also that they have not only respiratory implications, but they have also cardiovascular diseases. And particularly the hospitalized exacerbation of COPD are associated with a large increase in cardiovascular events, mortality and total mortality, and which makes us feel uncomfortable, apart from making the follow-up, to leaving this patient without prophylactic treatment, like cardiology do after a myocardial infarction. I know that there is no evidence, however, I mean, obviously in every patient with COPD, you have to consider the general risk factors, hypertension, hyperdyslipidemia, inactivity, pollution, and so on. But once you know that, particularly after an hospitalized exacerbation, which we know is an event associated with a large increase in mortality, we should probably not recommend, we cannot do that, but consider to adopt a prophylactic extra treatment for the increased risk. Thank you.
Thank you, Leo. Very important topics, the three that you choose. Before we go to Mark, I'd like to give Klaus the opportunity to address these three topics. Okay. Klaus, are you there?
Okay. I'm here, yeah, and I would like to give short, concise answers.
Please, go ahead.
Leo made very important and relevant points from my perspective. All three of them are extremely important. Let me start with the one, how we diagnose the disease. And of course, you're right. Clinical suspicion is of the highest importance. If there is a high clinical importance, high clinical suspicion, even if patients then have, let's say, obstructive airways disease and this goes away, that these so-called slow responders, when you give them a bronchodilator, there is a very nice study from Canada that showed very nicely that these patients are at a very high risk to develop COPD later on. So therefore, we have to reassess them. There is no doubt about it. I think the risk that we miss patients with COPD that have a normal fixed ratio is much lower. At least for the time being, we think it's much lower. Then the second point regarding why do we still measure post-bronchodilator FEV1 as the basis of to define the level of airflow limitation. You made an excellent point, and we had a lot of discussions about this issue. And I would say, for the time being, this is of course tradition. It has a long history, and we decided for making the diagnosis, it should be post-bronchodilator because there may be patients with asthma that are fully reversible. When you give them a bronchodilator, so to differentiate between COPD and asthma, whereas when you reassess the patient in a follow-up situation, we think it's not necessary any longer to give them to do a bronchodilator test, because then you would like to know where they are with the treatment you have given them. And then, of course, the pre-bronchodilator FEV1 is much more realistic than the post-bronchodilator FEV1 concerning what's happening to them in their daily life. And in addition to that, you made the point with regard to the CT scan. I'm totally with you. I was with Leo, we were as representatives of Gold in China a few months ago, and we learned there that in China, it's in many areas, it's easier to get a CT scan than spirometry. And therefore, I think we have to reconsider strategies around the world, how we can decide if a patient may have COPD or not, or how we may raise the clinical suspicion of COPD. And this has to do with access to certain methodologies. And of course, we also have to make progress how we can identify patients with early forms of disease, where spirometry is not really good. So I think that's a work in progress, and we have to improve to get better here. And the third point regarding cardiovascular diseases, I think there is no doubt, and you made the point very clear that we have to get much better when it comes to dealing with multimorbidity. How do we diagnose it? How do we make priorities? How do we define what patients should get what kind of treatments? We need a concerted action here, and I think the only way to make progress here is a holistic approach. So I would say if we only focus on the lung in COPD patients, we fall short. The suggestion you made is very wise. We have to consider what specific recommendations we can make, in particular after an exacerbation. This will not be evidence-based. There is no, because as far as yet there have been no studies performed in this regard. But I think that we should at least give recommendations what should be considered in the aftermath of an exacerbation. I think that's fair.
Thank you, Klaus. Leo, any rebuttal, any final comment?
Just one point on the post-bronchodilator use. It sounds strange, even if I know and I understand why you decided that, because it comes from tradition. That still we know that we express our percent predicted on reference values that are pre-bronchodilators.
Yep.
There is a study in Sweden, as you cited, but we don't basically have them. Anyway, that's the point. And no other comment. You said it. I mean, in cardiovascular, you are much more competent. In cardiovascular, you know every day. You verify every day in your daily clinic with the particularly with the severe COPD patient, where severity is a combination of spirometry, symptoms, and exacerbations. Not only spirometry. You should always address the complexity and manage the complexity together, the management of COPD. But otherwise, thank you very much for your careful response to my comments.
If I may contribute to this, the debate on pre-post bronchodilator, Eclipse showed many years ago that the bronchodilator response in COPD is not stable over time. So that means that you might have a patient with a positive bronchodilator response today, in 3 months' time is negative, in 6 months' time it turns again to be positive, and so forth. So in my opinion, I think that a bronchodilator test might be useful to characterize the patient the very first time you do spirometry. But from that point on, I agree with Klaus. What I'm interested as a clinician is to know how is the spirometry of that patient on treatment, already on bronchodilator treatment.
Yeah.
So there is no point in doing a post-bronchodilator unless I stop the bronchodilator treatment for 24 hours, which nobody does. I mean, no cardiologist asks the patient to stop antihypertensive drugs to measure blood pressure next morning. So yeah, bronchodilator test at the very first time for a characterization of the patient, knowing that it is not a stable characteristic, might help distinguishing it from asthma if it normalizes completely. But from that point on, I think we need to measure spirometry on treatment, I guess. I think that Klaus would agree with this. Klaus?
Yeah, I mean, there is no doubt that the so-called criteria for positive bronchodilator test is 200 ml and 12%. I think there is no solid basis for that, and we should stay away from that. The only thing that I think that really counts is when you have obstruction before bronchodilator and normal spirometry after bronchodilator. Then I think the differential diagnosis asthma is fair. But anything else, I think, makes no sense.
Good. Thank you, Leo. Thank you, Klaus.
Thank you.
Now we move to Mark Mirabilles, who will also give you his understanding and his opinion on the therapeutic part of your presentation. Mark?
Thank you. I think I'll move there if I can.
Okay. As long as you have a microphone, that's fine.
¿Sí? Va. Gracias. Mientras, por si no nos oyen lejos, pues aprovecho para, bueno, daros la bienvenida y agradecer a Álvaro que me haya invitado a volver aquí, donde tuve la oportunidad de estudiar hace ya muchos años. Y continuaré en inglés. ¿Ya funciona? Supongo que sí. Okay. ¿Sí? Okay. Thank you. So thank you, and hi, Klaus and Leo. So my task today is not to judge. I'm not qualified to judge what the Gold Committee has done, but to give an overview of aspects that may be controversial or nuances that some clinician reading the report and the recommendations may feel that perhaps need further clarifying. And I want to start with Ensifentrine. Well, Ensifentrine, as far as I know, it's not in the way to be available soon in Europe, but it is, or it will be very soon in the US, and it was included in the Gold. But I was reading the indication, the official approved indication for Ensifentrine, and it was just maintenance of adult patients with COPD. That means that it could potentially be placed anywhere in the therapeutic algorithm. So in the Gold document, it is placed after LABA in patients in continuation therapy, in patients who mainly complain of dyspnea, but it could very well be placed initially or in other steps. I understand that, I mean, it may be too risky to put a drug that we still don't know very well in initial steps of treatment, but potentially it could have been. And also, we have seen the effect on exacerbations, although the studies were not designed for exacerbations, but we are always talking about effects of drugs beyond the design of the clinical trials, and I do not need to give you more examples. But in this case, for example, there was also an effect on exacerbations, which is expected because they are anti-inflammatory drugs, and therefore they could have been also placed in the other area on exacerbations. So I understand, and I would say that despite all my speech, I agree with that. I would probably have done the same. I would have put this Ensifentrine after LABA in patients mainly complain of dyspnea, but I think that for the future, we will need to reevaluate this, and probably there will be more options for this new drug. Well, another aspect that is closer to clinical practice is the use of biologics. And Dupilumab has been presented and has been placed in the algorithm. And there are some aspects about Dupilumab that may be controversial. First is that the indication is for patients who have more than 300 blood eosinophils. But if you look at the clinical trials, at the two clinical trials that Klaus mentioned, you will see that at randomization, more than 25% of the patients had less than 240 or less than 220 blood eosinophils. Some people would say, well, they may see the glass full empty or half full or half empty. And some people may have thought, well, despite having more than 25% of the patients having blood eosinophils far below 300, it was still effective. But others may say, well, the reduction was only 30%, and this is probably because there were a lot of patients who had blood eosinophils below 300 at randomization. I don't know which one is true, but in any case, 30% reduction doesn't seem to be so spectacular for a biologic and is far from what we have seen with other biologics or with Dupilumab in asthma. So I think that this would be a very important, very good drug, but for a very few. And so guidelines, GOLD, other guidelines will need to be careful in the indication of this drug and be more precise probably to identify the population who respond the most. Another aspect is that despite the reduction, these were patients, you need to remember that inclusion criteria were over 30% FEV1 predicted. So not even the very severe patients were included in the trials, and no patients with significant bronchiectasis were included in the trials. So despite only severe COPD included, after treatment with triple plus Dupilumab, the mean exacerbations per year was 0.8. So close to 1 exacerbation per patient per year after triple plus Dupilumab. So there is a long way still to go. So it's not a suppressive drug for exacerbations. So we still need a lot more strategies to really prevent all exacerbations in this severe. So it could even be worse in the very severe patients with COPD who are more at risk for exacerbations and more at risk for hospitalizations and more at risk of death. Well, and finally, another aspect of Dupilumab, and has not been shown by Klaus, is again, the official indication of the drug. Because if you read the EMA and the FDA indication, it says that it is indicated for uncontrolled COPD. Uncontrolled COPD, not exacerbated or symptomatic, but uncontrolled. But it is not defined how control is defined in COPD. We have one definition in the Spanish guidelines about control. I'm sure that this is not what the FDA and the EMA meant by uncontrolled, but it is not specified in any other document what is uncontrolled. So in fact, I think that the GOLD did it right when it placed the drug on patients who exacerbated despite optimal inhaled therapy. But the official indication doesn't refer to exacerbations, but to control. Then another aspect that I would like to highlight is perhaps even more controversial, is the reintroduction of the LABA ICS. Some may think that this was a step back after the brave decision of the previous document to eliminate LABA ICS from the treatment algorithm of COPD. It has somewhat reappeared. I may understand the reasons. I know that there are a lot of patients out there on LABA ICS. Even in some countries, is the most widely used and the most widely accessible drug for COPD. And perhaps in some areas it has created problems or confusion. So, well, there is an algorithm, and Klaus showed the algorithm. I have some nuances with this algorithm. For example, it says that in patients with no exacerbation history with LABA ICS, consider to change to LABA-LAMA. Well, yes, patients who are does not suffer exacerbations on LABA ICS, maybe because they don't need the ICS, or maybe precisely because the ICS is doing its job. And we analyzed that in a recent ERS guideline on discontinuation of ICS using the GRADE methodology and trying to identify patients who could safely discontinue from ICS. And it was not the only criterion not to have any exacerbations on ICS, but other characteristics of the patients on top of that, basically the type of exacerbation, the type of inflammation, or the blood eosinophil counts. And on the other hand, in the same algorithm, it also says that patients on LABA ICS, if they have a previous positive response, they could, if they responded, they could continue on LABA ICS. So to me, this is a bit contradictory, because a patient on LABA ICS, a positive response means no exacerbations. But on the other side of the algorithm, patients without exacerbations can be moved to LABA-LAMA. And in contrast, patients who responded positive to LABA ICS can be continued with LABA ICS. So in some physicians may interpret that the same type of patients are given two different recommendations, either to continue LABA ICS or to move to LABA-LAMA. And my final remark would be that, again, in the continuation algorithm for patients with exacerbations, among the options, there is not the option of mucolytics or antioxidants. And in fact, in some other guidelines developed by the GRADE methodology, such as the Canadian guideline, the ERS ATS guideline, and other national guidelines, this is one option for patients who have exacerbations. They may not be extremely effective, but recent meta-analysis suggests a reduction of more than 20%. Remember, Dupilumab 30%. But also the costs are very different. The experience of use is very different. And also they are very well tolerated and cheap. So I think that this is something that should be included as an option in this algorithm. And this would be my, and I forgot one final remark. And I go back to Dupilumab. One aspect that I found interesting, and I think I fully support or I'm fully agree, is that in the recommendation for Dupilumab in the algorithm, it also mentions chronic bronchitis. Chronic bronchitis is not mentioned in the official indication of Dupilumab, but it was an inclusion criteria of the clinical trials. So I think that until we know more about the drug, we need to be restrictive in the indication and really focus on the patients who are more likely to respond. And in this regard, I think that including chronic bronchitis in the algorithm is well, I fully agree. I think it's a good move. And with this, I finish my review, and I'm open for discussion.
Thank you, Mark. Klaus, could you follow Mark's remarks?
I follow.
Would you like to address them?
Sure. Let me start with Ensifentrine. I must say I was very disappointed by the phase 3 studies that have been presented with Ensifentrine. I think I don't think that the phase 3 program that was presented here is really satisfactory. And one point that really I think is a no-go right now in these days is that you have no defined background medication. And this is what happened here. The second thing I think that should not be done any longer is that you have a primary endpoint that's lung function. Exacerbations were no endpoint at all. Therefore, of course, the question comes up, can you even analyze them in a group of individuals that's not enriched? I would say right now we do not understand the potential of this drug, and we need more data to be able to just to find out what this drug can do or cannot do. Regarding Dupilumab, I mean, you made very good points. EOS counts is an issue. But to be fair, patients had to have at least one eosinophil counts of at least 300. Of these two eosinophil counts that had been performed, all of them had to have at least 300 cells when they were included in the study. And then at randomization, there was a second count. And yes, he said there were patients who were below that. But The clinical signal was the same in patients that had a stable signal and those where there was some variability. And regarding uncontrolled, I am with you. I do not understand why this is in the official text. By the way, it's been used by EMA and FDA. That's also interesting. Both use this language. And I'm not sure how clinical data and study data translate into this kind of language, but I must say I'm very disappointed by that. I'm even more disappointed by the text regarding ensifentrine, because this doesn't tell you anything. And I think we should be more precise, and but this is a background. We decided in the science committee that we should have very clear recommendations when the use of Dupilumab can be considered. Regarding LABA ICS, to avoid a misunderstanding, we did not reintroduce LABA plus ICS. We do not recommend the use LABA plus ICS, but there are a lot of patients under LABA plus ICS. In Germany, around 40% of all COPD patients are treated with this combination. And this has historical reasons and reasons that doctors cannot differentiate asthma and COPD and so on. And we only try to make sort of a kind of a practical recommendation how to deal with that under these circumstances. I'm aware there are shortcomings. Not everything is based on data, but I think it's a step in the right direction to sort of just be pragmatic. And regarding mucolytics, you're right, mucolytics are cheap. They are, the tolerability is good. The problem with mucolytics is that most of the studies are very old. The patient groups are very heterogeneous. They have not been well characterized. And therefore, I think it's very difficult to understand. And then background medication was an issue. There were controversial findings, for example, with some of these mucolytics regarding ICS background use or not. We have to. I think it very much depends what studies will come up in the foreseeable future, and I think we can consider mucolytics, but again, the level of evidence that they work. And what they do is not as good as with the drugs that we have in the document in the algorithms right now.
Mark, your turn.
No, I think I mostly agree with what Klaus said. I think we have a similar point of view. I got the point about the mucolytics. It's true, the studies are older, the populations are more heterogeneous. And in fact, the biggest studies have been conducted in China and not in European populations. But it will be difficult to generate new evidence. So that's why there have been more and more meta-analyses and systematic reviews of the evidence. However, I think that the balance between the risks and benefits could be more favorable to the recommendation in some patients. But the point is well taken. And from the other aspects, I got the point about not recommending LABA-ICS again, but helping the clinicians to make decisions when the patients are already on LABA-ICS. And I understand that there is not much evidence specifically on what to do in these patients, what should be the pathway. And I recognize the effort on trying to elaborate an algorithm. However, some of the recommendations I think could be a bit more nuanced in order to avoid. In fact, when I saw the algorithm, I have some confusion that I mentioned during my intervention. I think that something could have been perhaps more refined.
Okay, good point.
If I may add to this debate, I can tell you, Mark, that the Gold Committee was extremely surprised and very disappointed by the approval of both Ensifentrine and Dupilumab by FDA and EMA, because the label does not say nothing. Say, oh, control of COPD. Okay, good. You said it, and you're right. Said, oh, at the beginning, at the end, when you... But it's surprising and disappointing. But FDA and EMA are regulators. Okay? Gold pretends to be a scientific institution. That's why we were very careful reading the inclusion-exclusion criteria of the trials. Dupi, in the inclusion criteria, the investigators said chronic bronchitis. They said it, not us. They said, no, the patient included here has to have chronic bronchitis. So we have to follow that. So you said chronic bronchitis, we have to follow that. They say more than 300 on triple. This is what we said. Oh, EMA or FDA say control of COPD. Well, what do you mean? And Ensifentrine, and Klaus said that if you look at the two trials, ENHANCE 1 and ENHANCE 2, the background therapy is all over the place. LABA, LAMA, triple, or nothing. And by the way, Ensifentrine, which is approved in the US, not in Europe, as you said, is very expensive. One treatment might cost more than $20,000 per year.
36,000.
6,000? I thought it was
36.
20. Oh, 26.
Per year.
So will you
36.
prescribe something which you do not really know where to position and pay 26,000? That's
so
and
the
I
US
think that Klaus is right. The clinical developmental program for this drug was poor. This does not mean, as you said, that the drug might have potential, but you have to show in a good clinical trial what and where is the position. Klaus, sorry, I interrupt you.
No, I just wanted to add to that. The price per year is $36,000 per year. And in the US, there are already 35,000 patients treated with ensifentrine.
Really?
This is quite remarkable.
My goodness. And this is nebulized. It's not an inhaler.
What I learned
it's nebulized.
in Philadelphia, that's quite surprising.
By the way, now that Klaus mentioned Philadelphia, you here in the room and also online have been very privileged this afternoon because you listened to Klaus presenting the changes, which was identical to what he said last week in Philadelphia. So you were, I think, very fortunate to be able to interact with this. So, any other comment?
No.
No? ¿Alguna pregunta de la audiencia, algún comentario? Aquí tengo un comentario en el chat de una persona, no diré el nombre, que está muy decepcionada porque hemos hecho la reunión en inglés y era muy interesante y no lo podía seguir. Yo le he contestado, lo siento, de verdad, pero la convocatoria decía que sería en inglés. Y si usted quiere hacer alguna pregunta en español, la pone en el chat y yo la traduzco, pero lo siento, de verdad. No hay más preguntas en la audiencia. Yo tengo alguna pregunta. Let me switch back to English. You said, and you were right, that Dupi decreases by 30% on top of triple, who already decreased by 30%. So it's 30% and then 30%. But I am always concerned with the remaining exacerbations. What are they? Are they exacerbations? Maybe they are not. Maybe there is heart failure. I don't know. Are they a different type of exacerbations that require different treatment? I have no idea. But I always say, this is not the first time I raise this question. What are the remaining exacerbations?
Well, I don't know either, but I have a suspicion. And my guess is that they are caused by infections, because these are the only cause, well, not the only, but the main cause that we cannot treat or prevent with inhaled steroids, with Dupilumab, or even with bronchodilators. So we can treat bronchodilations, we can improve exercise, we can improve inflammation, we can eliminate T2 inflammation, but bacteria are there and viruses are there. And therefore, I think that unless we use other strategies in some patients, such as treating chronic infection or colonization by some bugs, in particular in the most severe patients, we will still have some exacerbations despite our anti-inflammatory drugs.
Leo, Klaus, any comment?
Yeah.
Well,
Leo, you start.
Klaus.
I'm afraid that this. I believe that Mark is right, but I think it's even more complicated. I think this is a big mix of all kinds of reasons. Cardiovascular may play a major role. Leo mentioned HFpEF, heart failure with preserved ejection fraction. That's a big point. You know, one issue that we're dealing with is that all of these exacerbation studies have one major problem. The patients have not been well characterized. You know, there are no echo data. There are no values regarding cardiovascular risk markers. We do not, infectious causes have not really been investigated. We don't have CT scans. And of course, you know, the way we define exacerbations is so vague. It's not an exacerbation definition, it's a description. And it's not only vague, it's also not really specific. And therefore, we have a lot of open questions here. And I think we can only make progress if we do have more studies where patients are much more carefully characterized, where differential diagnoses are taken into consideration.
Characterize when stable and characterize during exacerbations.
Exactly.
Yeah, Leo.
Well, I can only support that. Particularly, as usual, I recommend to focus on the hospitalized exacerbation. The reason is that when they're there, you have all the tools to characterize, and nonetheless, they continue to say, you know, if the smoker is elderly and he has dyspnea or cough and sputum, that's an exacerbation of COPD. That's it. They don't take care of arrhythmia, of swelling, and heart failure or ischemic heart disease. I think that I fully agree with you, Klaus, that is more complicated for that. But having said that, Mark, you are absolutely right. I mean, it is reasonably simple to understand clinically when you have an infection. You know, cough and sputum, maybe fever. Then you have to, in any case, and I suspect that they have done that in the studies with Dupilumab, that you have to also to introduce the antibiotics when needed. But by definition, you should be a clinician, an internist. You should look at the patient. And you see the difference in the hospitalized. So the hospitalized usually are very difficult to characterize because they are complex, frail, elderly, and complex. And if you focus your attention, as we did in the recent observational studies in Italy, and you take the 75-year-old people, I mean, you see the mortality and the rehospitalization is even higher of what has been reported so far.
Good. Thank you, Leo. Leo, are you okay?
Yeah.
Okay, that's fine. Diego, you want to say something? Did you want to ask a...
Yes.
One question from the audience.
Thank you.
Do you mind to identify yourself?
Yes,
I know who you are.
Diego Gonzalez from the medical department at Chiesi in Spain. And my question is, since we presented the Ensifentrine for the symptoms algorithm, is not very crowded right now because exacerbations is plenty of treatment, but the symptoms area are not. You're just climbing from the from monotherapy to double bronchodilation. Ensifentrine, the results are subtle and they are nebulized, twice daily nebulized treatment. My question is, you got there non-pharmacological treatment, like, for instance, rehabilitation, which is not very stressed there, but could be highly beneficial for double bronchodilation patients, still symptomatic.
So you suggest that ensifentrine should be treated like rehab?
I'm suggesting that could you go stressing a little more to go to rehabilitation for those patients?
Oh, but it's there. Rehab is
symptomatic. Also, you mentioned non-pharmacological treatment, but it's not stress as.
Okay. Klaus, you want to say something? Did you get the question?
Yeah, I got the question. I mean, we have it there. We do not say rehab, we say non-pharmacological measures. This is, of course, algorithms tend to be too complicated and too populated. Therefore, you have to be very precise. The other issue is, of course, I mean, for example, we in our hospital, we offer every single patient that is in our hospital because of extubation, we offer each and every one of them a rehab. We can easily do that because we can send them to wherever we want. But most of them don't want to go. So there is a big selection bias in all these rehab trials, and this comes from the patient's willingness or unwillingness to undergo rehabilitation. And I think not only me, but also other members of the science committee believe that we need new forms of rehabilitation programs that are more decentralized, that are more closer to the patient's homes, and that are maybe even telemedicine-based and app-based. But for this, there is only limited data as yet. So I fully agree with you. This is underestimated and very important. There's no doubt about it. And therefore, it's a big part in the document. And by the way, this whole chapter on rehabilitation will be revised for the 2026 edition, because we were able to recruit Terry Trusters to the science committee, who is a worldwide expert, well-known expert in this area.
Wait until 2026, Diego. We said 7 p.m. is 2 to 7, so we are on time. Let me express here in English my gratitude to Klaus and Leo and Mark for participating in this webinar. I think I personally enjoyed, and I think it was a very vivid discussion, important points. So thank you very much. Let me switch back to Spanish now. Gracias por estar aquí. La sesión está grabada y estará colgada en la web de la cátedra. Y he visto que algunos de ustedes tomaban fotos, que están muy bien. Pero supongo que saben que si van a la página web de Gold hay un slide deck que se puede bajar y que por tanto es gratuito y se puede utilizar para su formación o para educación. Pero en fin. Back to English. Leo, Klaus, Mark, thank you very much. This has been a very informative webinar. I wish you have a nice evening. And thank you again. See you soon. Thank you very much.
Thank you. Privilege to be here. Ciao.
Bye.
Bye.
Se acabó. Buenas tardes. No sé vosotros qué pensáis.